Hello, everybody, and welcome to this week's episode on Fit as a Fiddle. We have a dear friend and colleague of mine joining us on the show today. Her name is Rachel Parrotta. She is also a pelvic floor physical therapist, a doctorate of physical therapy, and she works out in Long Island. She has an in-person office, and she also does telehealth throughout New York State as well. Rachel also works, very closely with all types of pelvic pain, pregnancy related, postpartum related, and menopause related issues, and really like across the lifespan, because pelvic floor is pelvic floor. We all have one, regardless of what gender you identify with and what part of your lifespan you're in at the moment. So I think we're gonna have a really great conversation regarding all the fun things that pelvic floor PTs kind of talk about on the side about the work that we do. So welcome onto the show today, Rachel.
Thank you. I'm so excited to be here with you and your listeners today.
Amazing. So we'll just get started with listeners just learning a little bit more about you and what brought you into physical therapy first, and then the very, kind of niche field of pelvic health as well, and kind of your background in athletic training as well.
Sure. So yes, I started my career as an athletic trainer. I became a certified athletic trainer in undergrad, and I was always really into sports. So I was a gymnast growing up. I was like really interested in the human body. We did a lot of strength and conditioning, obviously, as gymnasts. I also liked watching sports, and I was always curious when people were getting injured, like what was the injury? What was their rehab like? I had like a kind of a out of proportion interest in that compared to other kids, I feel like, that were watching sports. So I went into athletic training in undergrad, and I loved it. I loved being with the athletes. I loved the day-to-day challenges of having to troubleshoot on the fly and all of those fun things. And I always knew I wanted to go into PT school, but I got an opportunity after undergrad to travel with a men's minor league ice hockey team. And that was like a dream of mine. I just loved ice hockey at the time so much. So I took that job. I traveled around. It was an amazing experience. And, I learned a lot again about injury rehabilitation and thinking on the fly. And it was just a great experience. And then I jumped back to PT school thinking I would always work in sports. I just knew like I would be a sports physical therapist. I would apply to sports residency. And I started my career in physical therapy at a clinic that we had a lot of high school athletes. I loved working with them. But I developed like a side interest just personally in women's health, pregnancy, and birth. And I would secretly watch birth videos. I mean, not secret from anybody, but I would watch birth. I'd be like, well, is this weird that I like to watch birth? And I thought maybe I'd be a doula. And then I realized that I could study pregnancy and postpartum as a physical therapist. And that's where my transition into learning about pelvic health, once I became a PT, started to grow.
Amazing. That's actually really interesting that you had that transition. I feel like a lot of people who get into pelvic health either had or know somebody who's had some kind of pelvic floor dysfunction or just developed an interest in it in and of itself, just because it's so interesting and so many people don't talk about it. Even our like highly educated colleagues in medicine, and so many people, when I have conversations, a lot of friends who are, nurses and doctors, and I'll have conversations about what we do in pelvic health, and they're like, oh, I didn't know you could treat that, or I didn't know that was really a thing. We spent like, I don't know, like 45 minutes on it in like 4 years of med school. And so it's just really interesting because it's such a big part of quality of life. And that's birth is how you exist in this world. And, that's just a part of the natural part of the life cycle. And so making sure that we support birthing individuals and, pelvic health, again, it's not just about pregnancy or postpartum. Again, like we said in the beginning, across the lifespan, across genders, everyone has a pelvis. So, it just connects everything together. And I'm sure you can touch on this, Rachel, but you treat other things. I know you don't just treat the pelvis, right? You treat everything. And so that's a big misconception that people have about pelvic floor PT or pelvic health PT, or, we try to get away from women's health to feel more inclusive, but, most people who are birthing individuals have female anatomy and identify as women. So, we try to help them understand that it's not just about the pelvis. It's connected to literally everything else in your body. And so being a pelvic floor physical therapist helps us become a better physical therapist overall, right? So I'd love for you to just touch on that and maybe your journey and how, understanding the pelvis helped you take a look at the rest, everything else you did with orthopedics and sports. How has that helped you as a clinician overall?
Sure. It's a great question because I think people see them very separately. I had my career in sports and now I have a career in pelvic health, and people think, wow, those are really far apart specialties, but there's so much crossover, which is really super cool, from the fact that, let's say, the male athletes I worked with in ice hockey who identify as male, there's a lot of hip, groin, pubic area injuries. And I think that's really underserved in their population. Like when they're having trouble rehabbing from a hip surgery, or they have this athletic pubalgia, like pelvic health therapists are really amazing in that area. And that's like an underserved area for them. And then even to the point when we're with someone who's postpartum and they're leaking, let's say with running or exercise. And the coolest part can be sometimes when you show them, hey, this isn't really a problem with your pelvic floor at all. Like maybe this is a strategy you're using when you're breathing, or maybe like something with your running, like your soleus strength, your calf strength is like not where it should be. And then you kind of start to peter out in the run. Like that's one of my favorite things too. Like you're saying, we treat the whole body. And when you can show someone like, hey, your pelvic floor is not in this bad shape that you think it is, the cool thing is that it's just showing us something up the chain or down the chain is having trouble. I think that's really a fun part of being a pelvic health physical therapist.
Yeah, absolutely. And I think that because as physical therapists, we do that full body screen, we take a look at that person's gait pattern and the way that they're walking. The second we start seeing them through the waiting room or walk into a home visit, and, we watch them as they're getting up out of a chair and looking for compensations. And, we're taking a look at everything just from their natural functional capacity. And so I think that that's really helpful in putting all the pieces of the puzzle together to, really understand what is it that we can do to holistically optimize this patient. Not just, it's not just about the pelvis. It's not just about, somebody who has ankle stuff. It's not just about the ankle. Any orthopedic physical therapist who's studied well knows that, you have to look at the hip when someone has an ankle problem with the way that they're landing, So the pelvis just gives us another picture into, what are all of the things that we can look at. And also, like you just said, actually, maybe it's not the pelvis, maybe it's something else too. So it just gives us variety. And I think that it's really important as clinicians that even if you're not, if you're listening to this and you're a physical therapist and you're in a different field, I think it's really important to just get educated on the pelvis and the pelvic floor and just how it connects to the rest of the body. You don't necessarily have to treat postpartum or pregnancy. You don't necessarily need to do any internal pelvic floor evaluation, but there's so much that we can just learn and gain from each other to make sure that we are, giving our patients the best shot. So I totally agree with you on that whole piece. So let's dive into pregnancy and postpartum and preparing for birth, because I know that that's really the bulk of your patients that you see for the most part. I know that you see, male patients and female patients and all sorts of things. But I'd love for you to kind of just chime into what are kind of like the main diagnoses that you see and the main things that you're treating at the moment.
Sure. Yes. My practice has kind of shifted very much towards this pregnancy and postpartum phase in people's lives. I do work closely with a group of midwives here on Long Island. So I think that kind of has shifted it a little bit. Also, I have young children. So sometimes when you're in that time of your life, some of my social media content's very much geared towards the time of life that I'm in. And that kind of draws people in who are in similar time periods in their life. So I would say in pregnancy, the coolest thing is I'm starting to see a lot of people more for education and birth preparation. So what does that look like? Sometimes it's folks who are exercising a lot and they want to know, like, what should I scale? How should I scale? If I'm at CrossFit, like, what are some ideas? Or like, how do I look for maybe signs that my abdominals shouldn't be doing this exercise? Or I'm feeling this weird thing in my pelvis. So a lot of like preventative scaling ideas. How do I progress through a pregnancy and stay active and still also look out for things I might want to adjust? And I just love that approach. I think we're starting to get the word out a little bit more that we are here for that type of visit. instead of what used to happen, which is people always saying, I wish I would have known, I wish I would have known, after they give birth. So I love that. In pregnancy, I'm also doing a lot of what you said, like birth preparation and birth. There's a lot of factors in birth that are not in our control, but I do like to educate about like what happens to the pelvic floor. I think there's a lot of misconceptions that maybe the pelvic floor has to squeeze or tighten or Kegel to let a baby out. And the pelvic floor actually, as you know, has to, we say sometimes, get out of the way or yield or stretch. And sometimes this is the first place a person will hear that information, and that can really shift the way that someone's preparing for a birth. So I would say those are really more the preventative, preparing for birth visits. I do see folks who are having back pain or tailbone pain in pregnancy, pelvic girdle pain, which we use to describe pain at the pubic joint in the front or the sacroiliac joints in the back, people who are having pain down their leg, like a typical sciatic-like pain. Those are the kinds of things we're seeing in pregnancy.
Amazing.
Should I go into postpartum, or do you want to dive into
Yeah, let's talk about postpartum too.
Sure. So postpartum can be a really, I think, large range of challenges that we see in the postpartum. So I always tell people, like you were saying earlier, we think pelvic floor, we think pelvis, but really a lot of us pelvic floor PTs consider ourselves experts in the core as well, right? We're the ones seeing these clients through pregnancy and postpartum. And I think we're really well suited to treat the changes of the core, sometimes more than physical therapists that are not as familiar with the physiology of pregnancy. So I see folks for core concerns. We'll talk about diastasis. I see people for diastasis, or just overall feeling like the core is not working well or looking the way that people would like. As we travel kind of down from the core, after cesarean recovery, which can include scar treatment, returning to exercise. I do see a lot of folks have pelvic pain with sexual activity after cesarean. I see folks, let's say, after vaginal birth. Definitely also, we see a lot of pain with sexual activity after vaginal birth, if there's scar tissue involved, if someone had tearing and sutures. I see sometimes pain with sexual activity because the pelvic floor is overactive. So I think it's another myth that the pelvic floor will just be very stretched after a vaginal birth. And I'm starting to tell my clients, use this analogy of like, if you overstretch your hamstring, if you pull your hamstring, it doesn't feel loose after, right? It feels tight. And that we can also feel this in the pelvic floor. The pelvic floor actually can become shortened or overactive after birth, which I think surprises folks. So I'm seeing folks for pain with sexual activity, scar management, incontinence for sure after birth, which is both stress incontinence, coughing, laughing, sneezing, exercise, but also a lot of urgency, frequency. Urgent continence tends to really occur for a lot of folks after birth. And then also we'll talk about, I think, pelvic organ prolapse, which are changes to the vaginal walls that can occur after birth. And folks can feel pressure in the pelvic area or the vaginal area. And we work with them to get stronger overall, so there's not so much downward pressure, and help lead them through a rehabilitation process.
Amazing. You're speaking my language. One thing you said, Rachel, which I actually 100% agree, has been happening a lot more, I would say, over the last like 2 years, maybe 3, are the people who call me up and say, hey, I'm not really sure like what's right or wrong at the moment, but I would just like, I'm like pregnant, I'm like 3 months in, I'm 6 months in, and I just want to make sure everything is okay. I don't necessarily have any crazy complaints, or, they're like, there's maybe a little bit of lower back pain or something that's not, very interfering. But they're like, can we just go over what the pelvic floor is? And can I just learn a little bit more about what needs to happen during labor and delivery, and how can I make sure that I'm doing everything right after? And I'm like, thank you. Thank you for being here. Tell everyone you know. Because you're right. It's so many people. I mean, I remember the patient that I saw that I feel like the most empathy for in my whole life was a woman who, I mean, I have so much empathy for all my patients, but this was a woman who for 22 years had fecal incontinence, and her son was 22 years old, like finished college, and she had regular fecal incontinence. Like every day she would just, like soil her pants while she's at work, while she's driving home from work, while she's cooking dinner, random times. And she just thought that nobody could help her and this was normal. Like she really, truly was like, oh, everybody, you know, this must just be a very normal part of postpartum, you know, life. And I'm just always going to be like this. And I was like, oh my no, 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 no. There's so much we could do about this. And then, you know, once we started talking about it, she realized, she was like, she didn't know a lot about the female anatomy and how things worked, breathing patterns, how to control her pelvic floor muscles, how to control her core muscles. There was so many things that she learned. And I remember just like discharging her and leaving that session being like, I just wish we could get to people beforehand. And then this was maybe like 5 years ago. And so I think I see that a little bit more now, which is fantastic. And I think is also a good thing of social media, you know, kind of spreading the word and talking about, you know, different kinds of things and being more open about pregnancy and postpartum, and celebrities a little bit more coming out and talking about that kind of stuff as well, which is great. So yeah, so Rachel, thank you for going through all of those different diagnoses. For a lot of folks, you know, that might have been like a long list, but if you actually just look at each one of those items that Rachel just spoke about, there is like a whole world and wealth of knowledge. Like each of those we could have an entire podcast on, and we could probably just barely scratch the surface. So it's sort of just an overview for people to understand that there's lots of different things that, you know, you can take a look at, prevent and rehabilitate when it comes to pregnancy and birth and postpartum as well. And some of it is related to the muscles, and some of it is related to scar tissue, like we talked about with the C-sections and episiotomies and tearing. And sometimes it's a tightness problem, and sometimes it's a weakness problem. Sometimes it's both. Sometimes it's neither, and it's just a coordination problem, right? How many patients, Rachel, have you treated, or tell us about maybe the patient who swears that they feel like they can't do anything with their pelvic floor, and then you assess them, and by the end of the session, they can totally do everything, you know? Talk about that a little bit.
Yeah, well, I'll say that a lot of folks will come in and they'll say, I never knew how to Kegel. Like, it's not something that we learn. Like, we don't learn in gym class. I always say it's not your fault. Like, it's not as if you're in school in third grade and like, okay, this is your pelvic floor and this is how you're gonna engage it. And this is what it feels like. Here are some cues and this is how it lets go. And we don't have, a lot of people don't even have that muscle memory. Like, no one's gone over it. I always joke how it's like if someone told me to go throw a curveball, like I don't have that muscle memory. Like I don't know how to do that. So I think a lot of people come in and if you ask them to engage the pelvic floor, they cannot at first because they just don't have a pathway for it, because no one's ever gone through that with them. It's like a secret. Like someone says it in prenatal yoga, but no one, and everyone's sitting there saying, I don't really know what they're talking about. So the really great part of our work is that we can touch muscles, we can feel muscles, we can give all different kinds of cues because different things work for different folks. And we have all of these little, you know, tricks that we find over time, help people find their muscles, activate their muscles, use them in a way that is efficient. Muscles have to move in both directions. And that's where we can really help, where other providers that might not be able to do hands-on work aren't able to touch that piece as well.
Yeah, I love the curveball analogy. I'm going to start using that. I usually use the example of like trying to lift just your big toe up off the floor, or like trying to raise one eyebrow, or trying to whistle, or trying to wink. I'm like, there's a lot of people who don't know how to do those things the first time, but if you just practice, you could get it. You know, it's like, it's not that your nerve to that muscle area is severed. It's not like you can't, it's just, you haven't coordinated it. It's like tapping your head and rubbing your belly at the same time, or is it the other way around? Whatever. Yeah, tapping your head and rubbing your belly, I think. Yes. It's an interesting skill that it's not as obvious as a bicep curl or a squat or, you know, leg lifts. It's not something, you know, people, exactly like you said, people will cue it in a class and say, you know, in a Pilates class, in a postpartum yoga class or whatever, they'll say, engage your pelvic floor. Well, you know, unless you've been taught what that means, if somebody just said, raise your eyebrow and you've never done it before, you'd probably be like, I don't know how to do that. And you would just skip that part, right? Or you might think that you're doing it and you're just doing both eyebrows, or you might be closing your eyes, and you just don't know because it's so subtle. But yes, so pelvic floor physical therapists, at least ones that have, trained and worked with patients, can do external evaluations, internal evaluations of your pelvic floor muscles, folks. And we can actually tell you what you're doing, how you're doing it, and how we can optimize it. And sometimes you're doing it great. And sometimes we're not doing it at all, or something in between, and we can just tell you where you're at. And sometimes people are doing it, but they're also doing other things. And so I think part of it, and maybe we'll dive into this now, Rachel, is, talking about, is it just the pelvic floor exercises? Is it integrating it with other exercises? Is it using it in function? People are kind of get lost in a lot of stuff out there in the world and out there in social media, which is the bad thing about it, where someone just says, oh, do 100 Kegels a day and you'll be fine. So what do we as pelvic floor physical therapists feel about that, Rachel?
Sure. And it's a conversation that I have with a lot of clients because I think the information is confusing. And also on the physical therapy side, we are waiting for more and more research, and some people are participating in more research to answer some of these questions. So I tell folks that our pelvic floor is not meant to be squeezed all the time. Like, we don't go around doing Kegels. And what we've learned is that the pelvic floor is actually reactive and responsive to other movements in our body. So the overall goal for movement is not to have to really engage your pelvic floor, especially on easy type tasks. So if I'm just doing a squat to pick up a baby or pick up a weight, and it's, I don't know, not the heaviest thing in the world that I have to lift, then the goal should be that my body should be able to figure that out without me having to really engage everything I have. So the rehab process can look different for different clients. So what I do is I make sure my clients do have a pelvic floor that can go up and down relatively well. So let's use an example of someone postpartum. I want to make sure their pelvic floor can move in an isolated fashion. Their brain can find it. Nothing's impeding the movement. It can go up and down. And we might do some isolated pelvic floor work depending on that client's symptoms and what I feel in an assessment. For me, then the next thing I move on to is pelvic floor work with movement. So integrating that into different exercises, full body movements. And I think the question mark is, how much pelvic floor do we need in those integrated movements and how much do we not need? And I think that depends on the client, their symptoms, and a couple of different factors. So I think that's where the kind of the art of being a PT comes in, and trying to figure out, like, okay, how much of this isolated pelvic floor support do we need for this movement? For my clients, I use this phrase tension to task sometimes during the rehabilitation, which is a Julie Wiebe phrase, I believe. That's where I learned it. So trying to give the client an example of, if I'm getting something light off the floor, right? The task is very easy. I'm just picking up the spatula that I dropped. Then the tension should match that task. I shouldn't need a full pelvic floor engagement. If I'm back at the gym and I'm using a weight that is pretty heavy for me, and when I go to lift it, I feel like a little bit like, ooh, my pelvic floor may be bulging a little bit, or I feel like I might pee, then I might need more tension to match that task. And that's how I approach the rehab process, with the idea of eventually we shouldn't need to call on an isolated pelvic floor engagement unless, again, a task is very, very hard. Then we might need to have some strategies to match that task.
Amazing. That's just perfectly well said. And I think that it's really important for people to work with a pelvic floor physical therapist to know what those different levels of engagement or disengagement even are, because it's really hard to just know what that is very intuitively if you haven't been coached that properly and appropriately, and you know what it even means, right? So I talk to my patients about, there's like building this internal awareness, and sometimes it just takes like quiet understanding of practicing to get that, and then you can put it into different movements, exercises, functional activities. But until you develop that, and it might just take a little bit of time, once you get it, but you have to practice and you have to develop that. And there's some level of coaching, visual cues, hand or tactile cues that you can use, somebody else can use to help you. You can visualize your own pelvic floor, handheld mirror or selfie mode on your camera. You can use a lot of different strategies, and somebody who can help you with that is really important to make sure you're doing it effectively. So let's dive into diastasis now, to wrap up our fun debusting myths and things like that. So diastasis recti, just for listeners, it is not a severing of any muscles. It is just a lengthening of the tissues. That is a natural part of pregnancy. Just nearly 100% of people in their third trimester have some level of lengthening. Some people just to different degrees. It depends on how you carry the baby, your anatomy and your body physiology, your body mechanics during the pregnancy, your level of, your baby's head size, and lots of different things can impact and influence, along with your, amount of core, meaning the front of your abdomen. And along with that, the base of your core, which is your pelvic floor and everything around it, all of those areas and your diaphragm are your, whole part of your core. So all of that, how it worked pre-pregnancy can also affect your level of, your degree of diastasis. So just that's a background for everyone. And so Rachel, I just love for you to dive into kind of the fear mongering behind diastasis and what do we really need to know? And what do we really need to tell our patients about it?
Sure. So I think that there's been this pendulum swing where maybe nobody knew about diastasis for a while. And then the awareness really ticked up, which I think is a good thing. We need to know about the core in pregnancy and we need to study it and we need to know how to rehabilitate it. But I do think physical therapy took a little bit of a wrong turn that wasn't corrected fast enough, where we were telling folks that this widening was like a big caution sign not to do a lot of things. It was like, okay, if you have this diastasis, you definitely don't want to flex or come up and crunch. You definitely don't want to rotate. You definitely don't want to plank. And those became absolutes. And I think that limiting movement really goes against rehabilitation, like the tenets of rehabilitation. So what we were telling folks was that these muscles, they lengthened and they widened. And then we were saying, but don't do anything about it after. Just use a different muscle, right? So the diastasis has to do with your rectus abdominis. So then we were saying, well, don't use that ever again, but use your transversus, use a different muscle, and that's going to fix the problem. So I think looking back, I mean, I was trained at the beginning too. Ooh, be careful. We did like little head raises. Be careful, be careful. But over time, when I saw people move, I found that using the rectus is what actually made it more narrow for a lot of folks, depending on how they were using their bodies. That's how people get stronger. I saw people who were not exercising because of this fear, and that left them really weak. And like that, again, is not rehabilitation. So we were leaving people with really distended abdomens, have a lot of other musculoskeletal complaints. And we were saying, okay, this is the diastasis, but then we weren't giving any tools to help. So that's where I think there's been a lot of fear mongering. I see a lot of clients who for years haven't engaged in any exercise because of this messaging of you're going to do something wrong, you're going to injure it, you don't know what you're doing, you have to see a professional, and then people don't do anything. And I think that's really harmful for postpartum folks. So in my practice, there are a small percentage of folks that when I watch them move, we have to be a little bit more careful about what's happening at the diastasis and really kind of be mindful of the rehabilitation. So that's a small percentage, but instead we gave a blanket restriction on, let's say, everybody, when maybe only 5% of the population, I'm just making up that number, right, really needed more focus on this. And I find that most people I see really need just overall core strengthening and some education on how to watch pressure at the linea alba and what that looks like. So I do think the awareness went from awareness to a lot of fear, and the fear has kept people under rehabilitated and underloaded in their core.
Yeah, absolutely. And I think that what's been really helpful is also when I speak to patients and they bring that up as their first complaint in physical therapy, let's talk about all of the things that are going on. Is there a back pain? Is there concomitant pressure and prolapse symptoms? All of this put together is why we're working on strengthening your core, not because we're cosmetically just trying to reduce a gap. And help, and maybe like reiterating that in some sessions has been helpful for them to understand, oh, wow, I don't need to think about like a gap in my abdomen. Rather, I need to feel stronger. And the second that clicks and they actually feel stronger, they're totally in the program. And then they do the homework they stick with it. They go on to their, home exercise portal, and I can see them logging in more and be like, this is reinforcing that I'm feeling stronger. I'm moving my kid easier. Like everything's starting to become a little bit more agile and fluid, which is the point of us, right? To like guide them and coach them through that. So absolutely. And I'm glad that you brought that up today, Rachel, because I think it's one of those things that as pelvic health is evolving and growing, there is always going to be stuff that's changing. And we just need to make sure that we're on top of it. And, every field has, its places where we feel like we've gone too much in one direction or too much in another direction. But I think what's helpful is the research, sticking to patient outcomes and making sure we're really there to support our patients and making them feel better in every way. So a lot of that is, again, like I said, like the way that we're communicating to them. So hopefully, if you're a patient listening or your provider listening, that, can help you a little bit in guiding you with patients that come to you with a problem regarding their core strength or their diastasis as well. So wonderful. Rachel, this has been amazing. Do you have anything else that you'd like to add regarding your work? And also we want to know where people can find you as well.
Sure. So I would say just about my work, I love working with all folks. I love working with especially folks who really want to be active. Again, I think that's probably the sports background in me, right? So in pregnancy and postpartum, it's really fun for me to get people. I think all of us, if we're physical therapists and people really love movement, that's super fun for us. I also have plenty of folks where movement is a struggle, but I meet them where they're at and we're there to support them just the same.
Absolutely.
Clients can find me. I'm on Instagram, rachel.parrotta.dpt. And I have a practice called Parrotta Physical Therapy. And I see folks on Long Island, as you had mentioned earlier. And I do offer telehealth in New York.
Amazing. So everyone reach out. Rachel's a phenomenal provider and, an amazing colleague. We've been in lots of different, groups and workshops and webinars and, different things together over the last several years, and an excellent source of information on her Instagram as well. So I highly encourage, I'll tag you on Instagram on this post as well, but I highly encourage everyone to follow her work, share her work. A lot of the stuff that she says is very, broken down into real raw information that's very digestible and really helps people understand, just about their bodies a bit more and make sure that they're thinking about things differently if you weren't already. So thank you so much for being on the show today, Rachel. Thank you for all the work that you do, and hope we can have you again sometime soon.
Thank you. It was my pleasure. It's great to see you, and it was great to have this conversation.